Introduce the next speaker, Dr. Sarosh Saleem. She's a physician ethicist from Pakistan. Dr. Saleem is currently pursuing doctorate in healthcare ethics from St. Louis University, MO, USA. She's assistant professor of bioethics and founding head of bioethics department at Shalamar Medical and Dental College, Lahore, Pakistan. She has a keen interest in clinical ethics, consultation, cross-cultural and ethical issues, pediatric end-of-life, and research. In 2021, Dr. Saleem received Hans Joachim Schwager Award at ICCESC 2021. And we will now listen to her on the topic, Reclaiming Interest, Centering Children in Pakistan Pediatric Ethics Discourse.
Thank you so much. Thank you. First of all, I'd like to thank everybody, especially the committee and the center, for bringing us all together. And it's been a privilege and an honor for me to be a part of this group. And I think seeing from all the talks, I know that we're all talking about things that we're so passionate about. So I'll just quickly, so again, thank you, and I'll quickly move on to, around, okay. Oh yeah, okay, great. So I'm going to talk about some ethical issues, specifically talking about assent. And I work full-time, and I'm a full-time PhD student, and I was jet-lagged, and so here you go, you see my picture on the disclaimer slide. So that's what happens when you mix all these things together. But anyway, so my plan today is to just briefly share some background about healthcare system in Pakistan and talk about pediatric decision making and some of the challenges that we see in pediatric assent. And specifically, I'll talk about pediatric assent in research because it will help us probably understand better some of the issues, and kind of using it as an example, but it still connects to the clinical practice as well. And if I have time, I'll talk about a few of the initiatives that we have in Pakistan. So, Pakistan is fifth most populous country in the world, and interestingly, almost 45% of population are children under 18 years of age, and this is a huge population. And looking at the meager amount of GDP, the budget that we spend on healthcare, I mean, we can all just assume how much of it we spend on child care. And talking specifically about the healthcare system, I'll just briefly tell you that there's a private healthcare system and a public healthcare system. There are a few public-private partnerships happening and NGOs in last few years, but mostly it's private and public healthcare system, and kind of thinking of it as like two extreme ends of a very broad spectrum of healthcare system in terms of cost, in terms of quality of care, in terms of using modern technologies in healthcare. So the private healthcare system is very expensive, very high-tech, but obviously because of the economic situation, since the people have to pay out of their pocket, it's limited for a very small amount of the population, and most of the people have to access public healthcare system, which definitely has many resource limitations. So now talking specifically about pediatric decision making in Pakistan. So as I said, one of the major reasons or the logic behind decision making in Pakistan is the cost or the financial resources of the family or the parents, and that's one of the biggest reasons. Other than that, parents often make decisions, and as we've been talking about it, like there are close-knit families, family members make decisions. We're a paternalistic society, so a lot of times an elderly male member of the family or somebody who has the financial authority in the family makes the decisions for the children. So especially in a situation where we do not have much of support from the law and the state, it's kind of oftentimes very difficult to think about where is the locus of decision-making authority in this situation, and what role do the clinicians, pediatric clinicians, play in this? Because again, thinking about clinicians, it's also kind of important to think, one, that there's a very paternalistic culture even among physicians, clinicians, pediatricians in Pakistan, and also about thinking about that there is a wide diversity even in the clinical care providers, because even living within a same country, because of the socioeconomic disparities, they have different backgrounds, socioeconomic backgrounds, and also training backgrounds. So because a lot of our healthcare providers are trained in the West, and when they come to serve in Pakistan, they are mostly trained to Western bioethics value and decision-making values. So they assume that the patient or the parents, they have the decision-making power, and they will participate and they will be empowered to make decisions, but that does not happen. So kind of thinking about all of these things, it makes us see a lot of among social, cultural aspects, the main voice of the child is not heard or seen in the whole situation. And that's what my whole argument today is, like, how do we, as healthcare providers and pediatric ethicists, how do we ensure, what do we do to kind of help this voice come through in pediatric decision making? And that's why I'm using an example of assent in pediatric research, because a lot of research is done in pediatrics, and a lot of times it is an international collaboration. And since there are international guidelines for pediatric research, and obviously they include an assent, age-appropriate assent, we see a lot of problems, because assent is seen as a checklist in IRB whenever research is being reviewed, and everybody assumes that, okay, there should be an assent because that's a guideline. But from how I see it, there are some problems with it. First, assent is, first look at the assent's moral groundings. First, it is one of this moral grounding is on informed consent, which is on personal respecting a person and non-maleficence. So my argument against that is, like, we know empirically, we know from our own experiences that even adult patients and research participants, they are not fully informed, they are not empowered to make their own decisions as adults to be part of research or part of a treatment plan. Then how can we assume that children would be? So that's one of the things. But then I think one of the more contended, which I personally feel is like more flawed in our society, is the second part of assent, which has moral grounding as an engagement tool in research. So it's important because we empower children, we respect children, we let them be heard in the process, and also we educate them, right? So I think it causes some moral harm to our children, because we are talking about a child who has grown up or is growing up in a very paternalistic society, where social values, cultural values, religious values tell them to obey elders, to respect elders, not to confront with them, not to disagree with them. So it's kind of a moral harm, just assuming that when we are asking about these things, they will just say what they want to say, right? So we've been talking about these things since morning and since afternoon, that this is practically not possible. So just imagine a child who doesn't want to be a part of a research project, but his or her parents want his or her to be enrolled in the research study, or the other way around. And it's really important to kind of think of that way as well, that when a child wants to be enrolled in a project, and it's important to think because nowadays a lot of our younger generation is far more educated than their parents, at least in Pakistan. They have more access to technology and information. So what if they want to be part of a research project, but the parents don't agree with that? So we can't expect them to just stand up against them. It's kind of a moral harm of like the kind of dynamics or a harmony of their family. The other issue I have with the kind of moral harm it causes is we have a culture of not sharing information. So we just talked about, I think our colleague from Indonesia talked about, like, we don't share enough information with patients or parents and their families, not even with adult patients. So assuming that clinicians and the parents have already shared enough information with the child age appropriately, and then we are going in for a assent or maybe talking to them about being participating in the research project and assuming that they will be empowered enough to make a decision. And what if they really actually don't know anything about the clinical condition? So that can actually cause a moral harm. It can cause distrust among care providers and family members. So it's really important to kind of think that in a culture where children learn to obey or at least be respectful to authority, we cannot just assume that they would stand up against their parents or even clinicians or researchers because they're in a position of authority as well. So some of these issues, like they are problematic, they create a lot of problems, and I think one of the main reasons I again talked about assent in research is to kind of just highlight all of these cultural issues. And one of the important things is to obviously kind of reflect on how decisions are made in clinical practice as well, and how children can be or should be included in clinical practice. So even though I do not have very straightforward answers, there's stuff that we're trying back home. A lot of my colleagues and some of us are involved in different ways of education and modes of communication with other healthcare providers. Again, it's not from the state or the government. Most of this is on the voluntary basis. Most of it, my colleagues, they have interests in ethics or pediatric ethics. We have bioethics groups. We meet every other month virtually. We bring in cases and talk about that. And so we realized recently that a lot of us are pediatricians, and oftentimes we are talking about pediatric cases. So we've actually now introduced a pediatric bioethics group, and we plan to meet quarterly, bringing in cases, talk about these things. At least what we can do is like maybe reflect on our own practices, and we engage parents and family members in those meetings as well, and that also gives us a very good perspective of how we should be doing things. And then there are a couple of training courses going on. So I also kind of co-direct a diploma program, a year-long hybrid diploma program in healthcare ethics and professionalism, and we have separate modules for pediatric clinical ethics, pediatric research ethics, and for IRB training for IRB members. And we include these discussions in those trainings so that we can think about how we can help clinicians be part of these discussions, how we can engage researchers, and how we can ensure that IRB members just don't see assent as a part of a checklist, but they also ensure that researchers and clinicians are engaged. And it's really important to do that because as I said, there are different backgrounds of clinical care providers, so even their practices don't match. Even within an institution, there might be different practices going on. So it's really important to know what kind of decision-making processes in pediatrics are going on, and who are the clinicians doing that, and how they're doing it, so that the same can be incorporated in the research assent as well. And also kind of we've been discussing a lot about introducing multidisciplinary teams in pediatric decision making. So overall, the whole idea is to kind of think about how we can ensure. So the whole idea of my talk is not to argue that assent should not be there or it's not practical in our society. I think in one way or the other, we have to incorporate voices of these children. If not explicitly, then maybe in some other ways we have this responsibility to advocate for them. And so that's the whole purpose of kind of thinking about like how to engage children in these decision making. Right. So thank you so much.